In this video, we'll talk about inspection as part of the physical assessment of the abdomen. The first thing we want to look for is the contour of the abdomen. In order to get an accurate impression of someone's abdominal contour, they do need to be laying flat. So put the head of the bed all the way down and then make sure that no clothing or bedding is obstructing your view, and you can get a good picture. So of course a flat abdomen is just a pretty neutral contour from the chest towards the pelvis. A scaphoid abdomen is when we have the chest and then the abdomen dips in and we come back up to the pelvis. A rounded abdomen is a slight bulge over the abdomen compared to the chest and the pelvis, and then a protuberant abdomen is a significant bulge between the chest and the pelvis. My picture is obviously a little bit exaggerated, but you can picture a pregnant woman or someone with liver failure and a huge liver or huge amount of fluid taking up their entire abdomen. So it's just more of an obvious finding than a rounded abdomen. Of course, the contour isn't the only thing we can look at. We'll also make sure we're inspecting symmetry. The abdomen should be at least mostly equal on both sides. You might have an old scar from a surgery on one side that's not on the other, but we shouldn't have any lumps or masses on one side that don't match some kind of bulge on the other side. Symmetrical bulges are usually abdominal fat. Asymmetrical bulges are more likely to be an enlarged organ or even a tumor. We also want to look at the skin. We did already cover skin assessment though, so I'll leave that to you to go back and review. And finally, we'll look for any motion of the abdomen. Does the patient move their abdomen when they breathe? Is there any visible peristalsis in the abdomen? Or can you see any pulsations in the abdomen? We'll also talk about a few specific tests where we look for movement associated with a fluid wave, but we'll get there when we cover percussion. Lastly, we can assess the musculature of the abdomen. Specifically, if we ask the patient to raise their head, it will engage the abdominal muscles, and we can check to make sure there's no herniation or separation of any of those abdominal muscles. Although it may not be officially considered part of inspection, I want to review some x-rays with you as well, since this is something you'll frequently see on your patients, especially if you work in the inpatient environment. This x-ray view is called a KUB for kidneys, ureter, and bladder. The kidney, ureter, and bladder would all be in this region. Of course, your kidneys are a little higher. But they actually don't show up well on an x-ray unless there's some sort of stone in any of those works. So we use that view to also assess our GI tract. In this case, you can see the stomach hiding out way up in the corner here, and then all this darker black is intestinal gas moving through both the large and the small intestine. This is a very typical looking KUB. There are no issues identified, but let's look at a couple common findings you might see. This is an x-ray typical of someone with constipation. You can see some of the abdominal gas in here again, but you'll also notice that this darker white substance, this is all stool through the intestine. So we have some at the ascending colon, and then a large amount in the descending colon and into the rectum. So this patient is what you might see listed as full of stool. So they probably need some good constipation treatment. Lastly, on this patient, you can see what are called air fluid levels. And these are these straight lines here. This is typical of an intestinal obstruction of some kind. We'll take an x-ray with the patient laying down, and we should see a pretty normal distribution of gas. But then we'll take another picture with the patient upright, either sitting or standing. And if these air fluid levels appear, then we know that things are not moving appropriately through the intestines. Of course, it's not a nurse's job to officially read the x-rays, but it is a good idea for you to have some basic idea of what you're looking at when your patient gets an x-ray. So that does it for inspection. It's time to move on to auscultation.